Stem.
Okay, ma'am.
Okay, so if you've read and understood, considering its surgical pathology station, please tell me what are the differential diagnoses you'll consider for this patient?
Okay, ma'am. It may be the case of ulcerative colitis, Crohn's disease,
Yes.
colonic polyp, colonic carcinoma, or inflammatory bowel disease.
All right. How would you establish your diagnosis?
For established my diagnosis, I'll take the history, examination, and investigation.
Yes. What investigations would you ask for?
For this case, I do the fecal stool test for fecal blood and for calprotectin, and I also do the X-ray barium follow through, X-ray barium X-ray, and I can do the CT scan, and I also do the CBC. I get the macrocytic anemia, and I also consider the colonoscopy if the case is not acute.
Good. Please tell me, how would you define ulcerative colitis?
Okay, it's a chronic inflammatory disease
Yes.
involving all or part of the colon, confined to
Yes.
the mucosa, and almost always involve the rectum.
Good. What are the genes which are involved in this condition?
Mainly two gene, APC gene and P53 gene.
Yes,
And
and KRAS oncogene as well. Yes.
KRAS
All
plus.
right. Okay. Please tell me, how do these genes work?
Okay, ma'am. P53 gene acts the retard the growth,
Yes.
DNA repair, and apoptosis. And P53 form a complex and degrade the beta catenin,
Yes.
and proto-oncogene KRAS act in the form of dysplasia. They
Okay.
do the dysplasia.
Dysplasia. All right. Tell me, what are the etiology behind ulcerative colitis?
Mainly idiopathic and also
Yes.
having the immunological, environmental, and some genetic cause.
Good. Very good. And genetic, in that, which gene is involved?
APC gene and P53.
HLA-DR2.
Oh, sorry,
Yes.
ACLA yes, yes.
All right. Why would you be needing to, all right, if you could tell me, what treatment can you offer this patient?
Okay, for this patient, I'll consider the proctocolectomy and ileostomy. And for
Yes.
the ulcerative colitis, we also advise the patient to consult with the gastroenterologist and change the lifestyle and low residual diet, and steroid, antibiotic, aminosalicylic acids, immunomodulators,
Yes.
and also consider the surgical intervention. If the medical treatment is failed, the patient having the steroid dependency, having the toxic megacolon, bleeding, or that case will do the surgery.
Okay. Right. What I wanted to tell me, what are the differences between ulcerative colitis and Crohn's disease?
Okay, ma'am. Crohn's disease involves mainly the terminal ileum, and the
Yes.
ulcerative colitis mainly the rectum.
Yes.
And Crohn's spread from colon to mouth to anus, but ulcerative colitis rectum and colon. And
Okay.
the spread is transmural in case of Crohn's, and mucosal in case of the ulcerative colitis. And the Crohn's disease having the skip lesion, and there is a confluence lesion in the ulcerative
Good.
colitis. And
Good.
in case of the microscopic fissure, in case of Crohn's, you will get the cobblestone appearance, aphthoid ulcer, transmural spread, and non-causating granuloma.
Very
And
good.
in case of the ulcerative colitis, we get the cryptic abscess, inflammatory sense in the lamina propria, pseudo polyp, extensive mucosal ulceration,
Okay, please tell me, how would you or what are the effects, if you could tell me, the identify Duke and the TNM staging. So what
Yes,
are the
ma'am.
differences in these two?
Yes, in case of Dukes,
Yes.
there is three points A, B, C. In case of in A, the lesion in confined to the muscularis propria not invaded. In
Okay.
Dukes B, muscularis propria is invaded, and Duke C in the regional surrounding lymph node is involved. In case of TNM staging, T for the tumor stage, T1 submucosa, T2 muscularis propria, T3 confined up to the subserosa, T4 invade the serosa or surrounding structure. N0 no lymph node, N1 1 to 3 lymph node, N2 more than 3 lymph node. M0 no metastasis, M1 metastasis.
Okay, right. Just suppose if a patient presents and you establish that there are liver metastasis, then according to TNM staging, which stage would that be?
It will be M1.
Yes, or stage 4.
Stage 4, right?
Yes. Okay. Right. The patient with ulcerative colitis presents with, or you manage the patient with steroids most often, then what are the things you have to keep in your mind pre-operatively, considering patient has been taking long-term steroids?
Okay, ma'am. In case of the steroid patient having the steroid, I'll manage the patient in ICU
Okay.
with the multidisciplinary team approach, and I'll
Yes.
consider the hydrocortisone injection 6 hours for the patient.
Okay.
And I'll do the X-ray, regular
Yes.
X-ray.
And what is the condition that you would be aware of that can occur? Addisonian
Yes,
crisis.
toxic megacolon, perforation, hemorrhage.
No, Addisonian crisis. What is
Oh,
that?
yes, ma'am. Yes, I got
That I
additional
want you to tell
crisis.
me. Yes. What is
Yes.
it? What is the pathogenesis behind Addisonian crisis?
Sorry, ma'am.
Okay,
Forget,
right.
please.
Yes, next time. Tell me how the patient who has been taking long-term steroid could affect patient's glycemic control. Patient's glycemic control, if you could remember.
In case, no, ma'am.
Okay, there'll be hypoglycemic episodes. Why? Because there'll be increased insulin sensitivity. Okay.
Yes, ma'am.
What you were telling me later, how this patient will develop diarrhea? What is the process behind it?
Yes. Due to the malabsorption,
Yes.
infection, and
Yes.
gastroenteritis.
Yes, and motility will be increased.
Increased motility.
Yes, all right. So what are the vitamins which will be deficient in a patient
Yes,
with
ma'am.
ulcerative colitis?
A, D, E, K, and B12.
All right, okay. All right, okay. Yes, good. Could you please read this image for me?
Yes, ma'am. This is the colonoscopic view and the showing of the transmural spread of the lesion from
Yes.
mucosa to the serosa. There having the non-causating granuloma and some spacey mucosal lesion, edematous glistening.
Good. Thank you.